Good morning, everyone. Welcome to Pediatric Grand Rounds. Welcome to our applicants today. Enjoy the free breakfast. I don't think Hopkins has that. I have no idea. Today's speaker is Dr. Benjamin Cable from the Department of ENT. Dr. Cable was educated at West Point Walter Reed Medical Center and completed his pediatric fellowship training at the University of Iowa. He worked for many years in the Armed Forces, most recently at Triple Army Medical Center in Honolulu, where he served as the consultant to the U.S. Army Surgeon General. He has extensive cleft palate experience as a leader of Smile, Sound, and Sight medical missions and his work in the Army. He's extensively published, book chapters, presentations, course instructor at the American Academy of Pediatrics and the American Academy of Otolaryngology. He currently serves as the Program Advisory Committee for the American Academy of Otolaryngology. Please welcome Dr. Benjamin Cable.
Thanks, you guys. Good morning. I'll lay a couple things out here. And how many of you saw that picture in the newspaper? Anybody recognize that? No? All right. So we live in a world of guidelines, right, and rules. So and as we get more and more complex, there are more and more guidelines and rules. And one of the places I'm always fascinated by are airlines have lots of rules, right? And most of them are for pretty good reasons. We're getting in a metal tube that flies 500 miles an hour with other people flying in metal tubes. So it matters, but it also gets interesting. If you watched the progression of the emotional support animal topic, and I am not a critic of emotional support animals, so please don't say Dr. Cable doesn't like that, but it's interesting as human beings push the envelope and they're very creative in their approach to guidelines. So you may have seen a story right before this came out, this picture, Southwest Airlines has approved miniature ponies as emotional support animals. That's true. And I hate to be in those meetings, you know, where you're in a board meeting with executive people wearing suits, and they're, okay, boa constrictor, no. Crocodile, no. Miniature pony, all right, right? And you know there was a meeting like that, right? We've been in those things. So this guy brings in an emotional peacock in Atlanta airport the other day and had tons of pictures taken of it, and it was put up in the newspaper. Did the emotional support peacock make it through? Anybody? It did not. So emotional support peacocks have not yet been approved. And I just don't know logistically how would you do that, right? I mean, so they've had trouble. But in any case, again, no slight to emotional support animals. It's just humans are creative is the lesson there. What I want to do today is sort of similar, is allergy and sinusitis is this huge box of a topic where there are many guidelines. Every possible organization that's gotten together has written a guideline. We constantly get questions from our parents. We were mentioning sometimes adults have some of the same issues, and you hear a lot of different things. So what I hope to do in the next probably 35, maybe 40 minutes is go over a fairly practical approach to this population, because it's something, it's a group that we all see frequently. And to do that, I really want to run through cases. So there are very few slides here, which I know is always a risk. We like slides. But I'm going to actually give you a couple cases that we're going to talk about specifically, because these are the kids that we see in our clinic. So I've got 4 of them. Here's our first kiddo. This is a child coming to one of your clinics, a primary care clinic, a 4-year-old who's got copious nasal discharge for 5 days, has just been kicked out of preschool because it's green, and sent home. It was initially clear, but it became thick and green in the last 48 hours of those 5 days. Dad notes intermittent fevers in the first couple days, none that he measured, but no fever in the last couple days in 48 hours, so afebrile now. Father said productive cough, nighttime waking, off and on. Child's complained about sore throat here and there. Has been treated for similar symptoms twice in the last 3 months with amoxicillin. Both times got better a few days after that was given. And on exam, thick, grungy stuff coming out of the nose and going back down the throat, everything else normal. First, so this child, backing up, green runny nose 4 or 5 days, started out clear, became green, got kicked out of preschool, had a fever for a couple days, that's gone away, and is now home with Dad now having to take off work. Let me ask you a question you don't think is coming. So how many staff in here? Okay, we got a couple. What is your Press Ganey satisfaction related to in that visit? What does the parent want? Antibiotics, right? So dad's not there for your diagnosis and acumen and coming up with what's wrong. He's there for one thing, right, which Dr. Einsford just said. It's antibiotics. So this actually may be one of the toughest kids that you're going to see because you have a hard, topic to discuss, because what does this child have? You guys can jump in too. This child has a virus, right? This is the classic URI. It starts with constitutional symptoms, right? Kids get the fever and feel bad up front. That goes away, and then it turns into the green grungy stuff, right? So we have this going on, right? So that child has a URI. How many URIs does the average child have, healthy child have in a year? It's 6 to 8, right? It's 6 to 8. And how long does a URI last on average? Yeah, 6 to 9 days. So if you add that up, that's a good chunk of the year. So I get consults every so often that my kid is sick 7 times a year for a week, week and a half. And I have to tell mom, I appreciate that, but you have a perfectly healthy young lady in your house. That's not recurrent sinusitis, right? So that's tough, but that's a discussion to have. And I think I wouldn't say we've turned the tide, but parents sort of are understanding more now than they used to some of the costs of our antibiotics and some of the drawbacks to them, and they're potentially a little more receptive. But it's tough because this dad got amoxicillin twice, and it got better. Why? It was going to get better, right? So dad made it in on day 4. You gave the magic amoxicillin. Lo and behold, that child's better 2 days later because she was going to get better anyway. But is that his perception of what happened? He took work off. He went in. He paid for a prescription, and his child got better. Now you're telling me you're not going to give me antibiotics. And every so often we're wrong, right? So 10 days later it turns into a bad thing, and then he's back in your office saying, I knew it, and your star rating goes down on the Carilion star rating system, right? So that's a hard one to have, but that really speaks to how do we know when it's bacterial sinusitis. And question number 1, does mucus color indicate virus or bacterial? No, right? So we used to have that argument. I mean, people used to go back and forth. I think most of it we're teaching. It has no predictive factor at all. Clear, yellow, green, whatever color. Now, the only catch to that is most people can smell Pseudomonas, which is gross to say, but you can, if you've been around it, you know what it smells like, and you can say that's bacterial. But short of that, mucus color does not predict. It does not help you, and that's really what you're doing in that visit is you're trying to determine viral versus bacterial. There's no help there. How do we determine bacterial sinusitis? What's the big one? Time, and that's what we mentioned, right? Any physical signs that help you differentiate the two? Anything you can do on your physical exam. There's actually one. Extra credit for anybody over here in particular. No? It's unilateral pain to palpation. Now, how often do you see that? It's pretty rare. But that's the one that has shown actual statistical significance to have predictive, so pain over a sinus, right? But beyond that, the bottom line is you don't have many things in your exam that are going to give you bacterial versus viral. You don't. So it's largely time. So if you look at the AAP guideline, and it's actually very well written, it basically tells you 10 days or more of nasal congestion and discharge and or cough in a symptomatic child is more likely than not, I can tell you it has to be, more likely than not bacterial, and that's largely the definition we use. And that works well because we just mentioned the average virus is 6 to 9 days. It should be gone. Now, it doesn't mean we didn't have a virus because most bacterial sinusitis starts with something else. So it may very well have started with a virus and turned into a bacteria. But the 10-day mark is what we use. The AAP has come up with 2 other outs for you on this. Number 1 is really sick child, and there's nobody better in the hospital than this group to kind of look at a patient and say, not okay, right, sick. So 102.5 and above for more than 3 days, constitutional symptoms, an ill-appearing child can meet the definition of bacterial sinusitis because usually at that point the fever's gone away in the virus. If they're still febrile at day 3 and they've got grungy stuff and they look sick, statistically you're moving into that category, and the AP says we can call that bacterial sinusitis. It's a bit of an out. Now there's a third one that just came out because there were a lot of frustrated parents with that 10-day rule. Anybody know what it is with the latest guideline? It's called the double dip. Right? So there's a third one that instead of making them wait for 10 days, initially they had those constitutional symptoms, and then they had the nasal symptoms, and it all started to get better and go away, but then suddenly it turns around and it's getting worse again. So you're in that middle range. You're in the days 6, 7, 8, 9, right? And so they got the fever, they got the green runny discharge, but then everyone went away, the nose started to get better, and then all of a sudden it's back with a vengeance and they're febrile again. That is the addition in the newest guidelines, the third one they give you. And what happened there? What's the physiology? Right? Virus first, swelled up, sinus is closed off. What's a closed off sinus? It's a petri dish, right? So if you have mucus trapped in a warm, dark place with bacteria that everybody in this room has in their nose, you've got a petri dish, and that turned into a bacterial sinusitis. It's percolated. So that mom or dad is in your office at day 8. You're like, it's not 10 days. Get out of here. You know, 2 more days off of work at school. That's what happened with that first guideline, and that's where we started to get reasonable with it. So bacterial sinusitis is one of 3 things in your clinic, and the most common one by far is 10 days of symptoms of nasal discharge or cough. The other 2 that you have are really sick kid, 3 days or more with fever, sick child, or the double dip. Make sense? All right, now you got it. So let me just give you that one, and then we'll talk about treatment. So second kiddo now in your clinic, so no surprises here. 5-year-old now in your office, 2.5-week history now of gross nasal discharge, bad breath, cough. Her mom reports she's been somewhat more tired than normal, but otherwise without complaint. She was treated for an ear infection basically 3 weeks ago with a routine dose of amoxicillin, 40 milligrams per kilogram per day, which got better in 2 days and seemed to resolve as far as the pain goes. She had intermittent upper respiratory infections, but no other big medical history. She's got grungy stuff in her nose, and she's got a little cobblestoning in the back of her throat. So now she's had this for 2.5 weeks. She's got a history of some antibiotics 3 or 4 weeks ago that seemed to help, and now she's in your clinic. What does she have? You say it's okay. She's bacterial sinusitis, right? No mystery. There's no catch there. So this child meets the definition very clearly, and we all see these kids too. You say, oh, easy visit, right? What do we treat this child with? Or let me back up 1 second there. Mom's heard from family members that x-rays can be really helpful to getting to the bottom of this. Do we get an x-ray of her? Would that be helpful? Why? Wouldn't? Do what? Yeah. What do you, if a child's nose is full of snot and you do an x-ray, what are you going to see? Snot, right? So again, you're back in that phase of trying to figure out viral versus, you know it's probably bacterial at this point. So we used to do a lot of, and I'll show you the waters, there's this waters view, most of you probably won't ever see, where the person's looking up to the ceiling and you can see this cloudy maxillary sinus, and there's a clear one. We saw a lot of these in training, but we don't see these anymore. Now we start to see a lot of CAT scans. The AAP and every group around has really come down on this, is that we should not be radiating children for this, because if their nose is grungy, I'll bet my house what this is going to look like. It's positive. It does not help you. Now, there are catches we'll talk about later when we're worried about complications. We had one this week up on the ward we'll talk about, right? But this child who's in your clinic who's otherwise well should not have her head radiated, period. Why? This is a number of CT scans in the U.S. That's only up to 2007. It's gone exponential beyond that. It's very hard to go through our ER, not that we don't have a fantastic ER without a CAT scan for things, because it's medical legally an issue, but we do a ton of CAT scans on people. Now, there's a catch to that we're not going to see. We used to say in the 80s, you know, radiation doses for a human being through our lives, most of it was actually background. When you fly in that tube at 500 miles an hour, you actually get some radiation at 30,000 feet. You don't get here on the ground. It's small. Radon, other things. It used to be medical. Total lifetime dose was about 15%. We're up to half, and that was 7 or 8 years ago. It's probably now more than half that we're giving our population in our diagnostic studies, and that's an issue, particularly in kids, because they're much more radiosensitive. What does this look like? This is Hiroshima from the bombing at the end of World War II, and this is where this is ground zero where the Hiroshima bomb hit, and this is radiation dose essentially in what we call millisieverts. This is something we don't, physicists, we talk in rads, right, in gray and things like that, but our physicists use a different scale. There were no survivors in these first couple areas, but in this very first ring of survivors that we were able to track and people watched over many, many years, we know that group had a higher incidence of neoplastic disease, right? over time. It wasn't incredibly high, but it was clearly higher than baseline. And the key thing right here is, see, this is 5 to 100 millisieverts that these people absorbed in that radiation dose. What do you think a CAT scan is of the head or chest or head? So a CAT scan of the head is 2 millisieverts, a chest is 7, an abdomen is 8, and a PET scan is 45. Now, you guys don't do a lot of PET scans. We do in adults. But if you get a chest, abdomen, and pelvis, your child's in that ring. One shot, right? So we don't think about that very much. A chest scan is about 350 x-rays. Now, we are protocoling them better than we used to, so that dose is probably not 350 anymore, but the answer is it's pretty high. And we don't think a lot about that yet. But this is out of the Presidential Commission on Cancer a few years ago, this graph. And again, it's 7 for a chest and 8 for an abdomen on average. And again, 5 to 100 is that ring right there. That's pretty impressive. So we want to avoid radiation when we can. There are plenty of places, and we actually, that child we're going to talk about later got a CAT scan for good reason. But in this general population, please don't radiate them for any reason at all. This is susceptibility to radiation, and the graphs aren't super important, but the point is, the younger you are, where you guys are working, you're much more susceptible to radiation changes than you are when we get older. So we worry less. But kids and radiation we want to be very, very careful with the advent of ultrasound and all these other phenomenal techniques we're starting to see. We're doing less and less of these than we should be. That's really important. All right? So radiation for this child, to that mom's question, is that child does not need an X-ray and won't benefit from it. Now we've said that we've got sinusitis, so how do we treat it? What are the big 3 bugs in sinusitis? You guys can do this one. What are the big 3 bugs? What bacteria? Anybody? You said it. Strep? Staph, maybe not quite as much, but Moraxella and H. flu, right? So staph's in there. So the one that you, so the big 3 by far, and this is true for otitis media and for sinus. It's easy. It's all respiratory. So it's strep, H. flu, it's MCAT. That's still true, even with the pneumovax. It pushed a little bit to the other guys of the 3, but it's still there, right? Now, you got to come back to your way back to medical school, to pharmacology, to actually help you decide on medications. And it actually makes sense if you just think through it for a couple minutes. How does strep beat penicillin? What's its trick? What would you say? Say it again? Almost. That's a good one, but the other 2 use that. So hang on to that for a second. I'll come back to you. What's the other one? That's a good one, though. Yeah, you got it. Binding protein. What he meant to say, and you're right. So it's the docking protein. So strep alters the docking port for the penicillin ring, right? So it can't do it. But you answered the next question is, how do you overcome that? You flood it, right? So if you remember organic chemistry, you just throw more in there, right? And it'll dock. It doesn't care after a while. And that's where we came up with this whole high-dose amoxicillin thing, right? So most of us trained 20 to, or at least some of us, trained in 20 to 40 milligrams per kilogram, right? Did you see that or no? It was historic for you, right? Yeah, okay. All right. So a couple of us in the room trained at 20 to 40 milligrams per kilogram, right? And we don't talk like that anymore. Now we're 80 to 90 milligrams per kilogram. Why? That's why. Strep, period. So the resistance rates are at least 15 or 20% in the lowest part of the country, and they're up in 60 in others, but there's a lot of resistance. So that's where we came up with the high-dose amoxicillin or high-dose penicillin for strep. This is great for your other interviews, you guys. Remember this stuff. Now, you had mentioned beta-lactamase, right? Our other 2 guys, H. flu and MCAT, make beta-lactamase. Moraxella catarrhalis, almost 100% of it now makes beta-lactamase, right? Our other, the other one makes partial. But the bottom line is beta-lactamase is nothing more than a bolt cutter. And if you remember, penicillin's a ring, right? And you can throw in as gallons of it, but the bolt cutters just run around and cut every single ring you've got, and they just invalidate it. So going high dose is not going to help you. So what did we come up with? Clavulanic acid, right? We came up with augmentin, right? What else did we come up with? Cephalosporin is nothing more than an armor-plated ring, right? It's a ring that the bolt cutters can't get into. That's why the drug companies went that way. So what we did is we had to think about those big 3, and that's important to you when you're in the clinic with this child, just deciding what you want to do. So what the AAP has said is and it's very specific. There's one set of kids that can still, and I have to always read this one because it's so specific. There's only one set of kids that can get amoxicillin anymore with this disease at low dose, and it is age 2 years or older, uncomplicated sinusitis, do not attend daycare or school, who have not been treated with antimicrobial agents in the last 4 weeks. How many kids do you see that would meet that? None, right? So basically what they're saying is the low-dose amoxicillin is out now, and you really want to go to the higher-dose medicines first line with this child, because you're not doing anything with 40 milligrams per kilogram anymore. The infectious disease group has come out and said, just stop with the amoxicillin altogether, right? So they kind of went ahead of P on that. They're not in agreement. But the bottom line is you got to think it could be one of those three. How do I cover for that? So we go to the high-dose amox, and we do something, or cephalosporin, and we do something to prevent beta-lactamase, which is augmentin. Now, what is augmentin extra strength? That's a good marketing trick. What is it? Anybody know? All it is a formulation that allows you to take the amox high enough that it does not wipe out the child with clavulanate. Because what's the problem with clavulanate? Diarrhea, yes, tremendous diarrhea. So if you use the old amoxicillin or the old augmentin, the 400, right, you're going to, and to get up to 80 to 90 milligrams per kilogram of amox, you've got the clavulanate so high you've guaranteed diarrhea in the child. So the augmentin people sat around and had this brilliant ad campaign. They said, well, let's just bring up the amoxicillin compared to the clavulanate so we know we're going to dose it higher and call it extra strength, and that's what it is. But the point is it's just made the ratio of amoxicillin to clavulanate lets you go to the 80 to 90 milligrams per kilogram for your kiddo and keep the clavulanate workable but not destructive to the kid. So you should always use the 600 per 5 in the formulary. There's no role for the old. I don't know why the old ones are even in there anymore. They shouldn't be because we're just giving kids diarrhea if you're picking that. So it's the 600. It doesn't say extra strength in our formulary. It's just the 600 per 5. Or we go to a cephalosporin, Cephurox, some of the others. What about penicillin allergy? That's a tough one, right? So what's the cross-reactivity with penicillin and cephalosporins? The real one, yes, that's what I want.
That's like 2%.
That's exactly right. It's 2%. So we were trained that there's huge cross-reactivity between cephalosporins. It's 15, 20%. If you're allergic to penicillin, you can't do the others. Largely that was because there was cross-contamination in the factories. They were making them in the same place. But now that they make them more carefully, it's 1 to 2%. That's exactly right. So they're very clear on this. If a child is allergic to penicillin and it's non-anaphylaxis, right, then giving a cephalosporin is perfectly safe to do without testing, without going to the allergy period. Now, if they truly have an anaphylactic reaction now, they've even come to the point of saying, it's okay, but you may want to have them see the allergist. I would have them see the allergist, right? So 1 or 2% for anaphylaxis is probably not great, but that's something you just don't want to rule out whole classes of antibiotics, assuming a penicillin allergy. So in the times that you have that, it's worth investigating with our allergy immunology team, because a lot of times it's not going to be real and they're okay, and taking those off the table is hard. Because what did we used to use if you were penicillin allergic? What was the big antibiotic? Zithromax, right? Everybody loves Zithromax. Does Zithromax work anymore? I used to say partially. The answer is now no. It's worthless. It's sugar pill. And the AAP is very clear on that. So Bactrim and azithromycin are now to be condemned for use. They are for acute sinusitis. It is not an appropriate. The resistance is virtually universal. So it's not to be used anymore. So it's harder. So what else is in there? What's left? You said it? Clindamycin. How yummy is clindamycin 4 times a day? Yeah. Has anybody given clindamycin to their kid in liquid? You have? Wow, strong. How'd it go? Yeah. Clinda's tough, right? What else? Yeah, there you go. All right. Use tricks. What else? So now, if you look at the recommendations, linezolid is now on the list for acute routine sinusitis. Wow. Quinolones, which are not FDA approved in children yet to this degree, are now to be considered by the AAP diagram carefully. What's the risk in quinolones? Joint, right? Joint pain and rupture. Now, rupture tends to be in adults, particularly adults on steroids or older with Achilles rupture. It's pretty rare in kids. Kids can absolutely get joint pain and arthropathy, but it is reversible. So as long as you come off, we haven't seen clear cases of permanent arthropathy with it. So it might not be a bad choice, right? And Rocephin. So you're kind of stuck at that point. I mean, linezolid, Rocephin, and, yeah, a quinolone. All are effective but need to be thought of very carefully because there's implications to use them. So if you're penallergic, it's worth having, if you have those kids, it's worth investigating them a little bit further because that's a big deal. Most of the time, cephalosporins are going to be fine for those kids, right? What else? Oh, the final thing, the WASP prescription, wait and see prescriptions. The Academy of Pediatrics has put in their guideline, and I just add this, is even when they meet that indication, even this child in your clinic, it's still appropriate to give a prescription so they don't have to come back that says, why don't we just give this 3 or 5 more days, and if it clears, don't use it. There are a statistically significant number of kids, of course, that will clear sinusitis on their own. It's cleared sinusitis long before there were antibiotics, and having the wait and see prescription may be appropriate in some cases. It does avoid the visit coming back. There's clear evidence that they clear more quickly, that they clear more over the long term, meaning less recurrence with antibiotics than without. So I think that's justifiable, but they just put that in there, and I want to include that because that's a AP guideline. I don't know how many parents are going to wait 3 or 4 more days to go fill it at the pharmacy, but it is one of those things to throw in. How quickly should they feel better is the last part of this before we do our next one. When you give an antibiotic, how quickly should a kid feel better, ear infection or respiratory? 48? Yeah, 48 to 72 hours. And that's the other issue. So if it's not getting better at 72 hours, it's not working. If that child's still febrile, having symptoms, whether it's ear pain and an ear infection or not, the answer is 48 to 72 hours is right on. So you need to change the antibiotic. There's not a single study that's been written that looks at what you should change to. It doesn't exist. But it's in that list that we just talked about. You want to move up to a different one to see. We don't really tap sinuses anymore. If you send a child to me to put a needle in her sinus, I'm probably not going to do it unless you really need me to, and we'll need to go to sleep for that. But in the past, right, they did double tap. When they did ear infection studies, the kids got a needle through their eardrum with the pus, then they got antibiotics, and then they came back to get another needle through their eardrum to see if it cleared. Imagine doing that study today. I've had needles put through my eardrum, and it's not, yeah, those were the days of research, right? They don't do that anymore. All right. So next case. Let's move on to the recurrent kiddo. So next case, and what time do we have? What time is it? Oh, it's right in front of me. I'm sorry. All right, we're good. 4-year-old now comes to your clinic. He's now got this over and over. So we've got 3.5 months of multiple courses of more than 10 days each. We've been on 14-day courses of high-dose amoxicillin followed up by very appropriate augmentin, and those courses for 21 and 28 days each. But the child's now back with another episode, visible purulent nasal discharge, halitosis. Parents say, of course, they smoke outside, not inside. Maybe some seasonal allergies, never been tested. There's 14 kids in the preschool class, and otherwise healthy kiddo. So what about this? So now you've done everything right? You just went straight off of everything I said, and yet it's not working. They're back again, right? We've all seen this kiddo. So you've followed guidelines, and you're stuck, and now it's 3, 4, 5 times recurrent. What's going on? What's that? Gotta look for blockage. That's exactly right. ENT consult. I love it. So I didn't have to say it. The trick here, and this is where we'll segue into the other topics in sinusitis, is the most important paradigm shift in your mind with this child now is you have to think totally differently. Because every one of us in this room has some of those bacteria in our nose. There's 3 bacteria. I could culture one of those 3, if not 2, out of every nose in this room. The conversion from whatever's happening into that bacterial is now the question. So before, your question was, how do I get this cleared up with appropriate antibiotic? But now that it's not working, the mistake that we make in primary care many times is to keep chasing the magic antibiotic. But the most important, and this is the take-home message for this whole lecture, the answer in this child, in your thought process, is a 180 switch. You've got to move completely over to thinking not about the bacteria or the bugs, but what's creating the edema or the swelling in the nose that's making all those petri dishes, right? Because now it's about edema. The bugs are just taking advantage. They were before too. You're clearing it up and hoping to get them back to a baseline where their nose stayed open and healthy. But this child, she's got, in your clinic, she's got recurrent edema in her nose, The normal opening to the sinuses in kids are 2 millimeters across. So this maxillary sinus in a child is 4 or 5 centimeters across, but the ostia is 2 millimeters. Something is shutting that off consistently to the point that it's building up in there and it's breeding that petri dish and it's causing infection, right? What are the big causes of edema in kids' noses? We talked about one. So allergy is where we're going. So 80% of this population is going to have allergy. That's the big heavy hitter by far. You could just have the recurrent viruses. You might 6 to 8 is a mean. Maybe that child said 12. So sometimes it's bad luck in viruses. Allergies, huge one on the list. 80% of this population needs to have their allergy looked at. We're going to talk about that. What else? You'd mentioned it.
So some sort of actual structural.
Yes. Anatomic. So that's the 1, 2, 3. Is viruses, recurrent, too many. Number 2 is going to be allergy. Number 3 is going to be anatomic. That's going to be the majority of your problems, and you can kind of keep. Now there's others, and you don't want to miss the others, but that's really where I want to take you. You got to start thinking about those 3 things. And the first one's bad luck. You can't do anything, so you only have 2 to really work through. And it's amazing how many times you can help that particular child get better clinically. So number 1, allergy. 80% of these kids will have allergies. When do kids become allergic? Now, my very first quote said, my 8-month-old has terrible, terrible allergies. Is that a true statement? Probably not. Why? Right. He said they weren't exposed. Allergy requires exposure over time, and what it is, right, we're mounting an immune response that's inappropriate. So the body's building up for a fight for something that's not really dangerous. Dust mites, dogs, cats, whatever it is, it's building up an immune response, and you have to be exposed repeatedly to most things to be allergic. There's lots of, I have to be careful here because there's a lot of dogma with allergy, but it's amazing in the end, there's a lot you can do with it. People say you can't be allergic till you're at least in preschool or elementary school. That's not true. Nothing can't be, but it is pretty unusual. So the 8-month-old, the 2-year-old, most kids become allergic in a testable way between 3 and 5 or a little bit older. So the 18-month-old in your clinic, she's got dark circles under her eyes, I know it, and she's terrible allergies like I have. Not impossible, we don't ever dismiss parents, but unlikely, right? Probably other reasons there. But certainly when you get up in your preschool ages and grade school, now huge heavy hitter, very, very common. Allergic symptoms are pretty straightforward, and everybody in this room knows what they are, right? Runny nose, constantly clear, itchy, watery eyes. The allergic salute we talk about in kids, right, this guy, and sometimes they talk about the crease that kids will come in with in your clinic. Those things all make sense, but are certainly part of that process. What do we do with those kids? What can be done? Do we test all of them? Not necessarily, right? So if we know it's in 80% of kids, what's first-line therapy for nasal allergy? What is it? Sorry? Steroids, yes. So a lot of people will say antihistamines. It's not. Nasal steroids are first-line, period. They're better than antihistamines in the symptoms that we're talking about. It's not going to help the itchy, watery eyes as much, but for nasal things, recurrent issues, nasal steroids are better. What's FDA approval? What age? It's 3, right? Do we use it younger than 3? You do. It's probably, you know, the blood level of steroids, the systemic dose is infinitesimal. It's tiny. It's not 0, but it's close to 0. So I've gone younger than that, but knowing that most kids that age don't have it, it's not a common thing. But 3 and over, certainly empiric therapy, right, is certainly very, very reasonable at that point. There's a couple of tricks to using it. What is empiric therapy really, right? It's say we're guessing, we're treating, and if they get better, we were right. And that's a fancy word for guessing and seeing if it works. But that's a very low risk, FDA approved, significant efficacy. What are the biggest mistakes with Flonase? Almost everybody does it wrong.
Okay. Yeah, there you go. What you just did this
finger pointing thing. What is that?
The direction of which way?
Direction of flow, right? How do most people spray nose spray?
Just take it up
straight up, right? Even in TV commercials, the happy smiling child is spraying nasal whatever cord is called lately straight up their nose, right? But everyone in this room is put in an NG tube, right? Does the nose go up? It doesn't go up at all. It goes literally 90 degrees off from that. So if you spray a Flonase bottle out in the air, it does go pretty wide, but if you're going up, 98% of it's going on the anterior septum, and about a third of those kids are going to have nosebleeds in about 3 weeks because all you're doing is thinning the mucosa in the anterior 1 centimeter of the nose. There's no treatment in that, none. So the trick to it, and people come up with a very fancy directions. You must aim for the back corner of the eye at 7:30 on the clock. It just needs to go more back than up. But the big thing with Flonase bottles, everyone that I've seen has to point up to work. If you tilt it, it won't draw the medicine out of the bottom. So tilting it is no good. It won't pull the medicine into the sprayer. So you have to have the child or the adult lean over. And any direction that's more back than up is going to work because the spray comes out at a wide angle. And suddenly now you're treating turbinates, middle meatus, and all the things that you're supposed to be treating. The other thing about Flonase, how long does it take to work? Yeah, a couple weeks is the answer. So people, I just use Flonase when I get sick for a couple days. It works great. What you're using there is the saline in it. You're not using the medicine at all. It's a steroid. It has to build up in the tissue. So if you use Flonase, it's got to be every night for, I tell patients 3 weeks to really get full effect, but 7 to 10 days to really kick in, right? It's worthless in 3 days other than the moisturization you get from it. And I would say 85% of people miss that in Flonase. So it's simple, it's easy, it's much more effective that way. Question?
Found out of nasal saline then?
So saline, the answer is yes. Saline in studies doesn't show to have specific effects, but if you think about allergy, right? What is allergy? It's the particle getting in the nose. How long does a particle, if I put a blue food coloring dot in your nose, right, the cilia, if you remember those little cilia that constantly move mucus, it moves it out of the sinuses, back along the septum to swallow it. How long does that blue dot last in there? About 6 hours, actually. So when you get a dust mite particle or cat dander in your nose or on your turbinate, it stays there as it's moving back for about 6 hours before you swallow it, setting off a little immunologic hand grenade that whole time. So saline washes, take those particles off. So for allergy, saline's wonderful. Now it's hard in kids to do both saline and Flonase. So to me, Flonase is a little bit of both. So I think that's what I can do. Go ahead, ma'am.
Sinus washes.
Sinus washes.
Sinus washes.
Sinus washes are probably the best thing there is for allergy, period. I don't know a lot of kids under 6 that I've convinced to do it. Teenagers sometimes, not so much. Adults, about half, you know. So there's the wash is the key because you're washing off all those particles. It's like the reset button. So in Hawaii it was surfing, or if you surf the way I did, you're always under the water, having your head washed with saline front to back. No allergy problems at all. So you could go surfing like I did, or washing your nose, no question. Neti pot, squeeze bottles, as long as you keep them clean, are fantastic, period. And it's physiologic if you think about it. You're taking the allergen. You slept in a bed full of dust mites. Every one of us did last night, as gross as that is. We all have them. Our nose is loaded with those particles right now coming to breakfast. And if you wash those out before you come to work, it's going to be better if you're allergic to dust mites, right? Sorry for that.
Just one comment about the Flonase.
Please.
And again, I guess I'm not going to be biased. Maybe I'll be biased.
That's
but
okay.
It smells like a funeral home,
Yes.
and it drips down the back of the throat. So sometimes I will choose others, just not because they're better, but they're more likely to be used.
Which one do you like?
I've actually had really good luck more recently with Flonase Sensimist because it doesn't smell. It's a smaller volume and a finer spray, and the kids just tolerate it better.
Yeah, and I apologize. I shouldn't even use the word Flonase as commercial. A nasal steroid, and certainly there are.
But Flonase is the only one that smells now, and so a lot of kids don't like it. It really stinks.
Okay. Dasonex might be a little easier. There's a host of them. There's no clear evidence that one's better than another, just to make sure nobody writes me down for commercial bias. I have no financial interest in the Flonase people or the augmented people or anybody else. Yeah, so taste may be an issue. Absolutely. They say it smells like flowers, which to you is funeral home, but and I agree. So if it's bad, you want to do tolerance for sure. Okay. So those will help. Washes will help if you can get them to do it, but if that's going to be a wrestling match and you're going to be in tears before the Flonase, I'd rather just do the Flonase. Does that make sense? Any questions for that? Okay. What's second line then? We already said it. Antihistamine, right? So if we make some benefit on the Flonase and it's working but you're not there, then we add one of the non-stating antihistamines. Again, I don't have any interest in which one you use. There is clearly a tachyphylaxis effect, meaning if you use one antihistamine for a long time, it probably does become a little less effective. It may be good to switch antihistamines every so often. Doesn't matter which one you switch to, but rotating them probably keeps them a little more effective. Most patients will mention that, and they just need to find one that works for them and certainly can experiment. All of those medicines are over the counter now. That's a good and bad thing because they're still $24, $25. And for some of our folks, you can write them for Medicaid patients and they'll often fill it because they're not going to buy a $24 medication in many cases or can't. So things to think about. So we say, oh, it's over the counter, it's cheap. The other thing is the generics, of course, as you know, are fine. So the Flonase package or Nasonex is very pretty and colorful, but the Walmart version right next to it was probably made in the same place, right? So those are fine. If we're still stuck on empiric simple therapy, then we start talking about getting in a little deeper with it. That's probably ENT or certainly allergy consult, but we can absolutely test. There's two ways to test for allergy, and what are they? Skin test and RAS. So RAS testing, you'll hear, is not as effective as skin testing, true statement, but it's also very, very close. And it doesn't require you to come off of any medications, and it's a nice screen. So you're not going to get allergy shots based on it, but I'm here to tell you, parents love it. In our computer, it's become much, much cheaper. This used to be like a $1,000 test. It's not anymore. I think it's almost under $100 now. You don't want to order the 85 antigen panel, but the order here is southeastern profile. Have you seen that? You order southeast, you've got nods here. It gives you about 12 of the most common ones specific to Virginia. And that's going to give you a very nice cross-section of indoor things, molds, animals, trees, grasses, pollens. And when parents see that, totally negative or totally positive, it's helpful, right? And if it's dust mites, you can put the bed in the mattress cover and the pillow cover. That is helpful. We don't keep our kids inside from outdoor allergens, or we don't get rid of the cat, hopefully. I hate to do stuff like that. But you manage those kinds of things as best you can, and parents know it's there, and you keep going down the track. Can kids get immunotherapy? They can. So immunotherapy is probably, out of everything that we'll talk about, if we're really, really stuck, immunotherapy is the one treatment that we have that is unquestionably effective, randomized, double-blind, placebo-controlled studies in many continents over time, is a cure. So everything else we're doing to allergy is managing it. The Flonase and histamines, we're not taking allergy away. We're just trying to put the horse back in the barn a little bit. Immunotherapy can be 85% of the time a long-term cure to allergies. A couple catches that you guys are all aware of. If you're doing shots, it's a shot every week for a year, every 2 weeks a second year, and now most the big organizations recommend a minimum of 3 years of immunotherapy. It's a huge time investment. But we're starting to see sublingual therapy come out. Sublingual means instead of the shot, you put 2 drops under the tongue. Same antigens in most cases. Tremendous safety profile. It's got about 30 years of experience in Europe. That's about all they do in Europe. And very safe in kids. It's actually a higher safety profile than shots. Economically, it's a harder model to sell, not to say there's not bias, but it's starting to come to the United States, and I think as we see more of it, you know, you keep it in the fridge, it's good for about 6 months, it's 2 drops under the tongue before bed. My son did immunotherapy that way. Very clear evidence that's probably just about as efficacious as the shots. So I think you're going to, I'm sorry, it would be done at home. Yeah, exactly. So that trip in for the shot where you got to wait 20 minutes every week for a mom and a kid, or a father and a kid or a family is tough. So this would be at home. There's no agreement as to when kids can start as far as age to immunotherapy. There's no consensus statement. But again, most wouldn't even consider until 3 to 5. But everybody's different. We don't offer that in ENT here. Some do, but our immunologists are certainly running fantastic here. So that's a long-term cure. So there's lots of answers for that. But from your level, the first 2 is to really, even though you're treating infections, recurrent infections, we've switched in our mind, we start tackling the bigger picture issues. Allergy in this case. The other one, and we'll do our final one in 10 minutes, is anatomy. Anatomy is one of those things, you can look in the nose and see a severe septal deviation in some cases, but most of the time, honestly, that's going to come to us to look at. You'd mentioned we can do a quick nasopharyngoscopy and see deeper septal deviations. The most common thing we see by far is adenoid hypertrophy, like a cork in the back. And what we have found over time, ENTs got into doing sinus surgery in kids for a while in the 80s and 90s, and it turns out it works great for recurrent sinusitis. The cure rates were 98%. We were doing sinus surgery in kids, under the eye, under the brain. The group there backed up a little bit and said, what if we were a little more conservative and just took the adenoid out and see what happened? 80% of those kids didn't need sinus surgery anymore. So Dave Parsons, the surgeon that really brought around sinus surgery in kids from the adult world, came back and said, I've done way too many of these on kids. I'm thankful it's gone okay, but I over-operated. It should be adenoid first. So if we have adenoid enlargement, we can take that out as an ENT. That's a clear indication, recurrent sinusitis. There's tremendous efficacy with that. So anatomy kinds of things we'll look at. Occasionally, you can certainly do a soft tissue single X-ray to look at adenoids if you want to. One X-ray I'm not too worried about for radiation, but we can look to in clinic without it. So either way is fine. Both of those are acceptable. But in that child, those kinds of things we want to look at. You mentioned polyps, and this will close my discussion here. The last thing you don't want to miss in kids that are having recurrent sinusitis is a bigger systemic issue. That can be a harbinger for bad things. So always in the back of our mind, we're treating what we think is there, but we can't miss the things, right? That's always the other half of our mind. Cystic fibrosis presents this way, right? Immunologic deficiencies present this way, and a couple others. The key hallmarks are other infections. So if they're having upper stuff and they've had 4 pneumonias, lower risk, true pneumonias, they need a sweat chloride, period, or sequencing if you want to do that for CF, period. And at that point, if they're having other strange infections they shouldn't see, probably an immunologic workup, and that can start off as simple as immunoglobulins, CBC, and titers on their latest vaccines to see if they're immunocompetent. And you can do that in your clinic, or certainly have either us or the allergy immunology folks help you. But you don't want to miss those types of things. So generalized immunologic disorders, and the really little kids who have infection, cystic fibrosis, nasal polyps, those kinds of things. So if there's other infections going on top of that, have somebody see them or think broadly about that. Make sense? Okay, last one. So this kiddo, and I'll just use our kiddo here. We talked about allergy. This was sinus complications do occur, and so sometimes it breaks out of the area that it is and can get other places. So this is a 5-year-old young lady who had come in twice, a swollen eyelid and sinusitis. Both times her eye moved perfectly well. She was doing okay. Her vision was all right. She had stuff pouring out of her nose. We kept her. We put her on some IV antibiotics, and the eye went down very, very quickly, and we got her home. 4 days later, she's back with a puffy eye. Did the same thing. Third time she came in, and now she's got a puffy forehead, blottable with fluid in her forehead, and now her eye is a little bit worse. And this is her scan, and I'm going to blow it up here so you can see better. This is what sinuses should look like. So here's eyeball and eyeball, right? So this is an axial scan. Nose is up here, and you can see here's the eyeball, the optic nerve. Here's one of the ocular muscles. Here's the medial rectus, and here's ethmoid sinuses. They're completely clear. They're full of air, right? These ethmoid sinuses are not only not full of air, but you see there's a defect in the bone right here, and there's a pocket right here. You guys see that in the back? So this is an abscess that's broken through this really thin wall. This wall is called lamina propria, which is Latin for paper thin. It's amazing it doesn't happen every time we get sinusitis. But this is a paper thin layer, and this infection was there long enough that it got through a little crack or drilled a little hole and now has made an abscess. Now, luckily, it's under the periosteum still of the bone. This is not in the orbit, actually, technically. It's subperiosteal, but its next stop is to get into the orbit and cause trouble, right? And that's the level that we see. So the first level you get, we used to call preseptal cellulitis. Puffy eyelid is a misnomer. Now we actually come up with a few different names of it because that's actually not correct. The puffy eyelid is not a true cellulitis. If you took the eyelid off and cultured it, which we don't do, you don't see infection. It's just swelling. It's venous engorgement from this infection because the eyelid drains back through the veins and the sinuses. So that's called, it used to be called preseptal cellulitis. It's just a simple area of the eyelid. As long as the eye is fine, that's okay. Once it breaks through, it becomes subperiosteal. If it breaks through after that, it's true orbital. And if it goes to the back, it's cavernous sinus thrombosis. And that's a lecture into itself. But this child had an abscess that far back. What does she need? Yeah, so this is surgery now, right? So she definitely needs IV antibiotics in you guys. So the team admitted her. We admitted her again. And we were with them the whole time for this. The other 2 times, I don't think she needed the surgery. This time it had gone to that. So she went and got a little incision and went back and drained that. Forehead abscess, that was kind of a red herring. What was that? Do you remember? So does that go up on the forehead? It doesn't connect. She'd fallen at daycare, and it's on videotape, and she got a hematoma. So the team was worried she had Pott's puffy too, like an erosion through a frontal sinus. Does a 5-year-old have a frontal sinus? She doesn't. You don't get frontal sinuses until you're a teen. So she'd fallen and smacked her head and had a goose egg that got infected. So that was a red herring for us. But it was pus. So luckily through that same incision, Dr. Chen snuck up underneath and drained it too, bonus, and got that out. we took that drain out. But most importantly, if that's all you did, your problem is still here, right? And now you have a ready-made hole into the eye. So the other thing that child needs is a child that needs sinus surgery. So these ethmoids need to be, all these little honeycomb of cells need to be opened up so it's easier to flow out into the nose rather than the eye. It's path of least resistance. So she got sinus surgery that morning too, and those opened up. So hopefully now, even though we can't put that back, as long as it drains more easily into her nose, the cross fingers opus, she doesn't have trouble. So this is the case, complications of sinusitis. If the eye is involved, swollen eyelid, we even try to wait a little bit on CT scans because most of the time it's not a problem. But once she's having any trouble with eye movement or vision, severe pain to the eye, certainly intracranial complications, behavior issues, photophobia, stuff you guys know, that's when you get a CT scan and it's fine. Now, I said CT scan already. People, we went back and forth on this. What about MRI? Because if it could be central, that's controversial, and I'll just give you that one. The American College of Radiology says get both, not surprisingly. But who's taken a sedated kid down to 2 scans in a row, 1 MR, 1 CT? I can't imagine trying to do that or coordinate it, much less. So the American College of Radiology says get both. I think starting with CT makes the most sense. It's much better for abscess. It's not as good for central access things and dural enhancement. I agree with all that, but you've got to see the bone to make a decision. And if we really were stumped by it and it looked like it was going, we could go back for an MRI. That's opinion. The AP has no clear opinion on that. They say you can do either or. But to me, I think CT is the start. MRI doesn't have radiation, but we wouldn't see this level of detail. We wouldn't actually be able to even probably see that abscess well in an MRI. And it'd be a hard call to do surgery based on that. To me, this is one of the few cases in sinusitis where a low-dose CT scan is indicated. And I need to stop there. We are right at the end, so I'll let folks go. I'll stick around if there's questions, and thank you very much. I appreciate it.
This is actually more of a comment than a question,
Please.
But for the students especially, I would like to point out clear reasons for physical exam because I've had a few, I'm a pediatric oncologist like Dr. Dunsmore, and I've had a couple cases that I've picked up by looking up someone's nose, or we had a case recently of a young man who had a Burkitt's lymphoma of a tonsil. So I had a kid actually present with a recurrent lymphoma, and the reason I picked it up is because when I looked up his nose, he had no nasal septum. So just physical exam findings, very important. Don't forget to look.
Didn't mean to dismiss that. Anything else for the group?
Any other questions in the room?
Like I said, I'll stick around for a few minutes.
Perfect. Okay, for everyone who is on the line, sorry we did not get a chance to unmute the phones, but you can always email us at outreach@carillionclinic.org, and I can get them to our presenters. With that, we're going to go ahead and disconnect the phone lines now. Thank you all very much for joining us.